Hello everyone, welcome to Dr. Deepa's Learning Launch. I am Dr. Deepa and in today's session we will discuss the uremic platelet dysfunction, one of the most important acquired hemostatic dysfunctions in CKD patients and end-stage renal disease patients. A patient with CKD often presents with a bleeding episode that appears disproportionate to the platelet count. This is because the uremia has profound effects on the platelet function rather than the platelet number. The condition is very complex, multifactorial, involving various abnormalities in platelet adhesion, aggregation, granule release, and interaction with the endothelium, which is all worsened by the anemia and accumulation of toxic metabolites. So, understanding uremic bleeding is critical because these patients undergo frequent procedures, dialysis accesses, surgeries, biopsies, and may have trauma or surgical needs that require optimal hemostasis. Our aim today is to break this mechanism and clinical features, laboratory findings, and management strategies clearly and comprehensively. There are four major pillars in understanding the uremic bleeding. First is the platelet dysfunction, which is the main issue. Platelet count may be normal or mildly low, but the function is severely compromised. Second is the bleeding risk due to many converging factors like anemia, toxin accumulation, endothelial dysfunction, and abnormal platelet von Willebrand factor interaction. The third is always rule out additional causes such as medication induced disorders, liver diseases that can coexist, or a DIC that is developing. Finally, the management is a multi-step strategy because no single treatment completely normalizes the platelet function in CKD patients. The bleeding tendency of uremia arises from a convergence of multiple abnormalities. Anemia reduces the blood viscosity, which normally pushes the platelets to the wall, which is called margination. Uremic toxins, particularly the guanidinosuccinic acid, which is a nitric acid precursor, accumulates in the plasma, which inhibits the platelet functionality. Platelet adhesion is also reduced due to decreased GP1B expression and decreased high molecular weight von Willebrand factor multimers. Platelet aggregation is impaired because of decreased fibrinogen binding, reduced thromboxane A2 synthesis, and impaired granule release. Hemodialysis itself, while being helpful in the treatment of the disease, causes an ongoing platelet activation and membrane shedding. Thus, the platelet is constantly exposed to an environment where both the activation and inhibition occur inappropriately. If we understand the role of anemia and what it does in more detail, the red blood cells basically serve as a physical spacer that pushes the platelets towards the periphery of the bloodstream. This is very essential for a platelet vessel wall interaction. In uremic patients, the anemia is common due to EPO deficiency or erythropoietin deficiency and chronic inflammatory status. Lower hematocrit reduces the platelet margination, leading to a weaker adhesion and a greater bleeding tendency. Interestingly, simply increasing the hematocrit with RBC transfusion or erythropoietin therapy can measurably shorten the bleeding time, demonstrating how important RBC and platelet relationship is. Platelet adhesion in high shear vessels such as arterioles depends heavily on the interaction between GP1B and von Willebrand factor. Uremic patients show reduced expression of GP1B, which is the primary von Willebrand receptor on platelets. This reduces the large von Willebrand multimers, which are essential for firm platelet attachment. This combination significantly weakens the initial platelet tethering to the vessel wall. This effect is particularly prominent during procedures of vascular puncture and minor traumas. Platelet aggregation defects represents one of the most important contributor in uremic bleeding. First, fibrinogen binding to GP2B3A is impaired. Second, the uremic patient produces less thromboxane A2, which is the key activator for platelet recruitment and granule release. Third, the granule release is defective. Both dense granules like ADP and alpha granules release poorly. Finally, the plasma contains increased concentration of inhibitory substances such as guanidinosuccinic acid, which stimulates the nitric acid formation. Nitric oxide is a powerful platelet inhibitor, further compounding the dysfunction in uremic patients. Hemodialysis related platelet changes. Although dialysis improves the hemostasis by removing toxins, it simultaneously produces a platelet activation due to blood contact through artificial surfaces. This leads to an ongoing platelet degranulation, membrane shedding, and functional exhaustion. Even more importantly, the systemic heparin used during dialysis further increases the bleeding risk. Despite these issues, both hemodialysis and peritoneal dialysis are effective in improving the uremic bleeding overall. The clinical signs represent classical mucocutaneous bleeding patterns. GI bleeding is particularly frequent and can be life-threatening. Bleeding from venipuncture sites, access ports are also very common. Always consider contributing medications such as NSAIDs, antiplatelets, anticoagulants that may worsen the bleeding episode in these patients. Although uremia is an important cause for platelet dysfunction, it should never be assumed automatically in a CKD patient. CKD patients always have multiple comorbidities that can contribute to the bleeding episode. A structured evaluation helps in ruling out a misdiagnosis. The key point to remember is that laboratory abnormalities do not correlate perfectly with the bleeding risk. Some patients bleed significantly with only mild abnormalities, while the others have abnormal tests but do not bleed clinically. ADP-induced aggregation is typically reduced, but full platelet aggregation studies are rarely done routinely. So, mild thrombocytopenia can result from both a decreased production and a shortened survival due to chronic activation. So, all of these have to be looked at before the clinical diagnosis and the reason for bleeding is evaluated in a CKD patient. A uremic bleeding requires a multimodal treatment strategy. No single therapy fully reverses the platelet dysfunction. Dialysis is the most effective overall treatment because it removes the inhibitory toxins. The remaining therapies provide a temporary benefit and is often used only peri-procedurally. Some of the examples are DDAVP, increasing hematocrit, conjugated estrogens, cryoprecipitates, RBC transfusions, or erythropoietin therapy. Dialysis should always be viewed as a central therapy. Most studies show normalization or improvement in bleeding time after a dialysis session. Peritoneal dialysis avoids heparin exposure and may be useful in patients with a higher bleeding risk if the INR is deranged. Desmopressin is very useful to temporarily improve the hemostasis, particularly before a minor procedure. However, it has transient hyponatremia and fluid retention. So it must be used very cautiously in a dialysis patient. It is not a replacement for dialysis, it is only an adjunct. As mentioned earlier, an increase in the hematocrit improves the platelet margination and restores platelet vessel wall interaction. Both RBC transfusion and erythropoietin therapy shorten the bleeding time and reduce the bleeding tendency in a CKD patient. Conjugated estrogens are particularly useful when bleeding persists despite dialysis and DDAVP therapy. Their mechanism may involve reducing nitric oxide mediated platelet inhibition. A cryoprecipitate infusion is never the first line therapy, but it can be life saving in acute severe bleeding episodes. It delivers fibrinogen, von Willebrand factor, improving the platelet adhesion temporarily. So, to summarize, the uremic bleeding is a complex acquired hemostatic disorder characterized by profound platelet dysfunction driven by multiple interacting mechanisms. The clinical bleeding is typically mucocutaneous, and the laboratory abnormalities do not always predict the clinical severity. Management must be individualized, but the dialysis is the cornerstone for the therapy. Adjunctive therapy like DDAVP, correction of anemia, conjugated estrogens offer a temporary improvement and are especially useful around the surgical procedure timings. By understanding each component of the pathophysiology, we can tailor the treatment and improve outcomes in these high-risk patients. Thank you so much for staying tuned to Dr. Deepa's Learning Launch. I will be soon launching the platelet disorders course in my website, so stay tuned for getting the links.